And Derek, do you know if Doreen is going to try to present today as well?
I don't think she'll be available today because we are having exams this entire week. So, yeah.
Okay. Yeah. Okay. Oh, there she is, actually.
Oh.
Yeah, sometimes you want to focus on your exams, but other times activities like this can serve as some kind of distraction that set your mind even more prepared for the exam.
I wish that were the case. I actually have two presentations scheduled for this week. This one on Gemini and thesis progress at the academic forum at the university. So fingers crossed that goes well as well.
Yeah. My guess is that you do well at all of them.
Mhm.
That
They're
you're
waiting for
keeping
you.
your mind engaged.
Are you fine if we record or live stream the presentation, Derek, or should we maybe not do so?
I think I'm okay with it. I don't think there's going to be much of an issue since it's mostly feedback and for learning purposes.
Okay. All right. So I think we can get started. Today we have Derek and possibly Doreen talking about some of their analytical plans for the projects they're running. Derek, you're going to talk about the SUD project, is that right?
Yes, the SUD. Specifically, I'm going to take you through the SAP we drafted. So I didn't prepare a presentation per se, but I'll just take you through the document itself, which I believe I also shared the link with Leticia. So I think you can share with the group in case anyone has any additional comments that need to be addressed in the document itself. It's much easier to refer to them in case I forget them or miss them during the presentation. So you can just share in the messages.
Sounds good. We are ready for you whenever you feel ready.
Let me just turn off my camera because the internet here is a bit fidgety, but I'll start sharing ASAP. So, okay. Good morning or good afternoon, everyone. My name is Derrick Kamaro, and I'm here on behalf of the SUD team to present our SAP for psychometric analysis for a study being done at Moi Teaching and Referral Hospital in Eldoret, Kenya. I'll give you a bit of background context with regards to the project itself. So this project focuses on evaluating the performance of a culturally adapted substance use assessment tools in the Kenyan clinical population, specifically ASSIST and INDUC. Substance use and substance use disorder continue to increase globally, including alcohol, tobacco, opioid, and illicit drug use. However, in many low and middle-income countries, including Kenya, substance use remains under-identified within the healthcare system, partly because appropriate screening tools are not widely implemented. An additional challenge is that substance use among women is often understudied and underreported, despite the fact that substance use in women can have important intergenerational, social, and health impacts. So, women also face unique cultural barriers, stigmas, leading to reduced access to care, which can limit accurate assessment and treatment. So, one important strength of this overall project is that it intentionally includes women through the recruitment in antenatal and postnatal clinics, allowing us to better understand substance risk in this often overlooked population. And this inclusion helps us to address the important gap in substance use research in low research settings. And for this reason, our study's aim is to adapt and validate two widely used substance use instruments, the ASSIST and INDUC, within the Kenyan healthcare context, ensuring that these tools are culturally appropriate and applicable to both men and women receiving care in the healthcare system. So the primary objective or the overall broad objective of this is to evaluate the performance of the culturally adapted substance use assessment tools among the adult outpatients at Moi Teaching and Referral Hospital, with our secondary objectives being to assess the psychometric properties of the adapted assist and induct instruments, and secondly, to evaluate the ability of assist to identify individuals with substance use disorder using the DSM-5 guided clinical diagnosis as a reference standard. So an overview of the study itself. This is a cross-sectional study, and it has two main components. The first one being the psychometric validation component, which evaluates the reliability and constant validity of the instruments. And secondly, the clinical validation component, which assesses the diagnostic accuracy of assist in identifying substance use disorder. In the psychometric analysis, we used cross-sectional data from 465 adult outpatients recruited from the emergency and antenatal post clinics. And in the clinical validation component, we used a case control study design consisting of 120 clinically diagnosed SUD cases and 400 controls drawn from the outpatient sample previously used in the psychometric aspect, leading to a total for around 520 participants to be used in the clinical validation. In the selection criteria, the study population included participants drawn from various clinics, including the emergency department, the antenatal clinic and postnatal clinic, substance use outpatient clinic, and alcohol rehabilitation. And all participants had to be aged 18 or older and able to provide informed consent. And individuals who were severely ill or medically unstable or unable to participate in the interviews were excluded from the study itself. These are just the specifications or minor details with regards to the participants included.
Derrick, for that eligibility criteria, so the numbers you gave us about the 520, all of them already met the criteria.
Yes, already met the criteria because we already have the data has already been collected.
Okay, got it.
Okay, so for sample size, for the psychometric validation, sample size calculations were performed separately for the emergency department and the antenatal postnatal clinics due to variations in prevalence. And we used the Fisher's exact finite population criterion, and we obtained a total sample size of 465 after finite adjustment for the exact number of participants available at both clinics. So as you can see here, the total sample size that we had after adjustment from the emergency departments was 305 after finite adjustment. Then from the antenatal clinic, we got 160 participants, leading to a total of 465 participants who we used or were enrolled for the psychometric validation aspect of the study. So for the clinical validation component, the sample size was calculated assuming target sensitivity of 95%, a minimum acceptable area under the curve of 65%, because we decided to be a bit more lenient with the acceptability percentage here for the area under the curve, because these tools have not been validated in this context. So we are hoping that with this adjustment and a significance level of 5% and a statistical power of 80, we got a total sample size of 120 SUD cases, which were obtained from the various substance use clinics at the department. So for the clinical validation, we'll also draw a 400 non-SUD confirmed participants or with no formal clinical diagnosis, which will be drawn from the initial 465, leading to a total of 520 participants who will be used for the clinical validation aspect of our study.
Derrick, a follow-up question. You talk about the 120 SUD cases. How was the characterization done? Diagnosis was done for these patients? Sorry if I missed that.
All these participants were clinically diagnosed using DSM-5 criteria by clinicians at the center. So there are
Okay.
participants currently undergoing treatment for various substance use disorders. So they're all confirmed cases.
Mm-hmm. Got it.
Okay. Okay, so with regards to the data descriptions, all the data was collected through structured interviews, administered questionnaire conducted by trained research assistants, and the two primary instruments that were used in this study were the ASSIST tool, which is the alcohol, smoking, and substance use involvement screening tool. This is a WHO. This is a screening tool developed by the World Health Organization to detect the risk of substance use and related problems in healthcare. And this assesses multiple substances, including alcohol, tobacco, cannabis, cocaine, amphetamine, sedatives, and other substances. And it consists of 8 questions per substance, covering lifetime use, recent use, cravings, problems related to use, and failed attempts to control. And the responses to question 2 through 7 generate a substance-specific involvement score, and the scores range from 0 to 39 for each substance, with higher scores indicating greater substance use involvement. The assist itself has been internationally used and supports screening, especially for brief interventions and referral approaches. And previous studies have demonstrated good reliability and validity across diverse populations and healthcare settings. So this instrument has been applied in several African contexts, including South Africa, Nigeria, and Ethiopia, where it was shown to have acceptable psychometric performance. So we are hoping that similar findings can also be displayed in our population. The second tool that was also psychometrically validated was the inventory of substance use consequence, or INDAC. An INDAC is a self-reported questionnaire designed to measure negative consequences associated with alcohol and drug use, and its key features is that it is derived from the drink inventory of consequences and consists of 50 items divided into five major domains, assessing the physical consequences, the interpersonal consequences, intrapersonal, impulse control, and social responsibility consequences. And each item is scored on a 4-point frequency scale ranging from 0 as never and 3 to almost stable. And the total scores for this tool range from 0 to 150, with higher scores indicating greater severity of substance-related consequences. Although this does not have specific categorization with regards to how severe the consequences are, similar to ASSIST's risk assessment. So this, with regards to data management, all data were entered directly into REDCap, cleaned, and data sets were securely exported for statistical analysis. And all of the data has been identified.
Can we go back to this section on the data management? One thing that I think would be beneficial here is describing what was this process about. For instance, missing data, it would be nice to have I apologize if you have a section down there, but it would be nice to have an own section for missing data, to talk about if you did any imputation, if you inspected patterns, and you, since I'm assuming that this is the plan for you to go on and do the analysis, I want to see the shelf for tables, possible figures that you would do to inspect missing data as well. Does it make sense?
It makes sense, but I don't think I included them in this presentation per se. But with regards to missing data, as per previous observation and review of the data, we actually had very minimal, since most of this data was primarily collected under most of the missing data, or at least the missing parameters in the data can be clearly explained throughout data collection. So in this context, they might not have a significant impact because most of the data had been completely filled. So I guess that's why I didn't
But then,
include
but still, even though that might be the case, we need to be very explicit that we're going to inspect that and show those results. So my suggestion is for you to, I'll add comments as you go, but add separate sections within the data management for missing data, for checking outliers, and specifically going about what changes you're going to do in the data as well.
Okay, I'll incorporate that into the SAP.
Keep going.
Okay.
Yeah, 1 minute, Derrick, please. Wow, in line with your comment, I'm wondering, where do we draw the line between data management and exploratory analysis?
Yeah, that's a good point. I'm not sure if you are talking about the naming of the session itself or the concept, but on my perception, I don't mind how the section is called as long as we have the content there. So if Derek prefers calling data management and then maybe have a separate section called exploratory data analysis, that is totally fine. I just want to have both. I just want to have the content there.
Okay. Okay, so I guess I'll just proceed to a brief overview of the variables collected. So in the variables that we have in our data set, we have different demographic characteristics as they can be seen here, like age, sex, and clinical settings. We have overall assist scores for each respective substance, depending on the participant's use, and total scores. We also have induc, and in a separate data set for the 120 participants, we also have all the demographic characteristics in addition to the DSM-5 clinical diagnosis, which specifically says they have a substance use disorder, yes or no, and which specific substance use disorder they have. With regards to the statistical principles, all statistical tests will be conducted using a two-sided significance of 0.05, and the 95 confidence interval will be reported for key estimates. Missing data are expected to be minimal, like I previously mentioned, due to interview and administered nature of the questionnaires, and therefore most of the analysis will mostly involve complete case analysis. Analysis for this study will involve R version 4.5. And like I previously said, we have two specific populations for the psychometric analysis, 465 participants who completed both the assessed and induct data. And we have the clinical analysis population, which is 120 SUD confirmed cases and 400 controls with valid assist scores and DSM-5 status documented. So this is a simple description of how the descriptive statistics will be done. All the continuous variables such as the assist, the age, induct will be summarized using their means and appropriate standard deviation based on their distribution with me. So I might consider either mean or median or interquartile range to best summarize the data. As for the categorical variables, they will be reported in terms of frequencies and percentages or proportions. And for the clinical component, participants will also be summarized separately based on the SUD cases so that we can get a better understanding of the SUD cases and the non-SUD controls. Then this is the overall guidance of the analysis, my analysis for this data. Initially, the data the questionnaires before being administered underwent a cultural adaptation and translation of the instrument. And these summaries, all these study instruments had to be translated to Kiswahili using the WHO adaptation and translation framework, which involves forward translation from the original language, which is English, to Kiswahili, and independent back translation from English into English to assess consistency with the original items. We also there was also review of the discrepancies and to resolve any ambiguous or culturally inappropriate wording, and revision of the translated items to actually improve clarity and cultural relevance. This process was aimed to ensure that the adapted instruments maintained conceptual meaning of the original tools while remaining understandable and culturally appropriate for the Kenyan population. So, down to the psychometric validation aspect. The first analysis will evaluate the psychometric properties of the assist instrument, where we'll start with the reliability, where the internal consistency will be assessed using Cronbach's alpha for each substance-specific module in the assist tool, with values greater than 0.7 being considered as acceptable, and item total correlation will also be identified to examine and identify poorly performing items within the tool itself. Then construct validity will be assessed using confirmatory factor analysis, where each substance model will be tested for a unidimensional factor structure, meaning the specific 8 questions should assess the specific substance as indicated, meaning that the items are related to the substance via single latent factor. And before performing the CFA, we'll also do factorability assessment to assess the sample size appropriateness using KM and Bartlett sets for sphericity, just to confirm in case we have any omissions due to missing or incomplete data. So we'll need to reassess the data before we actually start CFA. Model fit will be evaluated using several standard indices, including the CFA, TLI, root mean square, and SRMR, with the specific preference thresholds as seen in the document. Then we'll proceed with the psychometric validation for the INDUC, where we'll start with the internal consistency, which will be assessed through Cronbach's alpha for both the total score and for each of the 5 consequence domains. And the construct validity will also be assessed through confirmatory factor analysis, testing the expected 5 structure or five domains previously known in the INDUC tool itself. We'll also compare this with a single factor model in order to test or compare for comparison and assess fit with regards to our data, and to determine whether the multidimensional structure of the INDUC itself, hence the 5 domains, the physical consequences, interpersonal, intrapersonal, impulse control, and social reliability, also holds within this population. Then, for the last part, we'll actually proceed with the clinical validation, which is the final component where we'll evaluate the diagnostic performance of the assist instruments using a receiver-operated characteristic ORC analysis, which will be used to assess how well assist scores discriminate between individuals with or without the DSM-5 substance use disorders confirmed by the clinician. And the area under the curve will be calculated with the appropriate 95% confidence intervals, and the area under the curves will be interpreted as 0.8 or higher indicates for good diagnostic accuracy, and or 0.9 for excellent accuracy. Sensitivity and specificity will be calculated across the possible score thresholds, and the optimal cutoff point will be determined using Uden's index, which maximizes the combined sensitivity and specificity. In addition to this, the empirically derived cutoff performance will be compared to the WHO recommended assist thresholds. And finally, we'll examine the distribution of the DSM-5 SUD assist cutoff points or assist WHO risk categories to determine whether higher categories correspond to higher prevalence. So basically, since we already have confirmed diagnosis, we'll actually see if the categorization presented by WHO holds some meaning the cutoff points for mild, moderate, and minimum. We're expecting that participants in the minimum category to demonstrate lower prevalences in the 120 participants. So this is just an overall assessment to see if the presented structure for WHO assist as still holds in this population. But with regards to our cutoff determination, we'll only be determining whether assist can at least say that a person has substance use or no substance use, meaning anything high, any person rating below mild, and moderate and high will be considered as participants having SUD. Since we cannot actually move forward to assess the appropriate cutoffs because the diagnoses were presented as binary outcomes. Below are a list of the tables that I will actually be using to present my data. The first one is the assist internal consistency models, where I'll present the Cronbach's alpha, the mean and item total scores, and if any items were flagged or deleted, they will also be stated for each specific module. Then this is for the factorability assessment, where I'll need to assess if the sample is still appropriate for factorability before proceeding with the CFA. And this is the table which I will use to present my results. And this table 10.1C is the assist CFA model fit, which will compare the unidimensional model. Then 10.1b will be the standardized factor loadings example for the alcohol use mode, where I'll compare and report the standardized loadings plus the standard errors and p-values for the respective alcohol use. For example, this one is for alcohol use. Then this one will be the table for the induct reliability, where I'll test and compare the total and the 5 domains. And these will be the Cronbach alpha for each specific domain. And this one, table 10.2b, will be induct CFA model comparison, where I'll compare the five factor model versus the one factor to see how they compare within this population. I'm sorry, I do not know what happened with the table numbers. They seem to be a bit repetitive. So yeah, induct factor
Yeah,
load.
I was gonna say that you can restart the number for the tables starting at 1. You don't need to
Yeah,
follow the number of the sections themselves.
okay.
So like, for instance, this would be table 3, table 2, because otherwise I would makes me think that you already have 10 tables in your document, and that doesn't seem to be the case.
Okay. I think I tried to change this last minute, but I think it mixed things up. So
No problem. No problem. It's just a visual change. That's fine.
lastly, I think I already covered the factor loading for each specific of the 5 domains. Then I think this will be the table for the clinical validation of assist, where I'll assess the diagnostic accuracy per respective substances, since we'll have a total of 120 cases plus control. Although these numbers will change depending on the specific substance itself. And I'll report the area under the curve, the optimal Udens cutoff point, the sensitivity and specificity for each respective substances based on the prevalences. Then this table 10.3b, or the one I'm currently highlighting, will be the diagnostic indices at the cutoff points, where I'll compare the WHO cutoff points to see how they affect the sensitivity or specificity within this population, and the Udens optimal cutoff point. But this will just be for simply mild, meaning a person has no SUD versus a person has SUD, since we only have a binary outcome for cutoff point determination in our context. But the top part will simply compare the WHO cutoffs and see how they change within specificity and sensitivity in the data sets we're using. This will be a simple confusion matrix of the chosen cutoff for each respective substance. And lastly, we'll assess the distribution of the DSM-5 across the different assist risk categories. Like I said, since I'll be assessing the WHO standards, I'll be assessing the WHO cutoffs and to see how well the participants in the low category correlate with the prevalence in the 120 participants to assess if the overall structure, the expected distribution in the assist tool still holds in this population, where we'll anticipate that participants who have higher scores will probably have a higher prevalence in the DSM-5 and so forth. Going up, the proportional decrease. I think that concludes a list of the tables, but most of these are just visual presentational assessments. Some of these tables will be condensed and not included in the final report, but they'll just help us better understand and explore the data for.
Great presentation, Derrick. As you went by the tables, I started adding a few comments. For starters, I think you should be explicit on your table 1 characterization of your sample, which is you would of course use that for the manuscript by the end, but then it's also important for your exploratory data analysis overall. A table 2 that describes the outcomes themselves. What is the distribution of assist, distribution of drink across your patients or patient collection sites or patient samples. Tables and figures for missing data patterns would be great to see here as well, because this is about I want to say this is like a meta-analysis document, in the sense that you are talking about the process of analyzing the data and not necessarily describing your results as in a manuscript. So I want to have, I would advise you to have those preliminary tables that usually don't go into the manuscript because we want to be sure that we cover those as well. The word I was looking at is intentional in the way that we perform the analysis.
Okay, I think I will prepare a draft since it's mostly compiling and condensing these into presentable format. So I think we can work on that.
Sure. Yeah.
Yeah, because most
The
are the tables are just for the how we'll explore the data and different possibilities, but it's not the final result that will actually be included in the report. So yeah.
Mhm. You mentioned the DSM-5 score on the table 10 3D. Is that also described on your instruments?
DSM-5 score. Which table?
Yes.
I'm sorry,
Table 10 3D.
10.3D.
Yeah, the DSM-5 SUD.
Oh, this just means it's just DSM-5 guided diagnosis. So it's just mostly that we already know that the participants were diagnosed by clinicians who use the DSM-5 as a guidance.
Oh, okay.
Yes.
So it's a binary then.
Yes, it's still binary. That's why the biggest issue with this, we cannot absolutely determine the cutoffs for low, moderate, since our diagnosis were actually made in binary format and not in risk levels.
Okay. So changes to two columns, yes and no. Because the way that it looks like, well, it looks like it's a single thing, and I'm assuming you would have the yes and patients that are positive and patients that are negative to compare the scores. And what is the score that goes into here? Is this assist?
Yes, this will be overall just an overall assessment of how the WHO cutoffs behave within our data set. Will they be able to determine, will we observe a trend that is expected? Since we're expecting that most of the participants with low risk will probably have a very low prevalence of the substance use. Moderate will probably have a higher and so forth. So we are trying to explore and see if the WHO cutoff points do actually present to some degree some pattern that is expected.
Relation.
Yes, or relationship within the DSM. Since we cannot determine the specific cutoffs because of how the diagnosis was made.
Okay. So maybe what you could do here, now I'm thinking about the layout of this table, because if you are comparing low, moderate, and high for all of the drugs that you're assessing, in this case, you're showing alcohol and tobacco, but it could be more.
Yes.
Maybe it would make sense for the assist criteria to be on the columns. So you would have low assist, medium assist, and high assist, and the cells would be the proportion for the DSM-5 SUD.
Oh, okay. So instead of having a longer table, we'll have a wider one.
Yeah, I think so, because otherwise you're going to repeat low, moderate, and high, low, moderate, high multiple times, and they're going to repeat alcohol, alcohol, tobacco, tobacco, tobacco. And in this pivot table, you would have a single row by drug, so it would be probably easier to interpret. I don't know. It's
Okay.
just a suggestion. The data is going to be the same, but the way that you represent is going to be different. Yeah.
Okay.
Let me see. I had a few other notes here and there as well. One comment on the software section is on the statistical principles section 6.4. You could be a bit more specific on the software they're going to use, specify the packages if you can. Like, for instance, confirmatory factor analysis is going to be done with package X. Exploratory data analysis is going to be done with package Y, just so we know what's going to be your plan. You don't have to 100% stick to it, but it's nice to have a guidance.
Oh, okay.
On the, what was I going to say? Oh yeah, so on the data management section, you talk about how the data is going to be saved. It's either going to come from RedCap on the raw data, and after it's cleaned, it's going to be saved on Jukebox. My recommendation here is to be very specific, or either add a link to the Jukebox, and then the link, of course, needs to be private, so only folks that have access should have access to the link. Or you could mention who is the owner for the folder. You could mention who has access to the folder, and just so we don't lose track of the process as the analysis is being conducted.
Okay.
But other than that, I think that if you specify the tables that I mentioned and a few other minor things, I think that this is a pretty good job overall. And if you guys go for the analysis and stick to this, you should be having a good path forward. So, congrats.
Thank you. And once we started, I think most of the analysis, I think, will come back for presentation of the initial results so that we can have further discussions on how the process is going and how we might actually navigate it. So yes, thank you.
Perfect. Anyone else has comments for Derrick or questions?
Yeah, I was just thinking, if the data is already available on RedCap, I'm trying to figure out why it would still be necessary to save it on Dropbox. I mean, would there be any difference between the two data sets, Derrick?
That's a good question.
I'm actually not very sure how to answer, but I think from my perspective, I think Dukebox makes it a bit more centralized, since RedCap might be more local based from where the data was actually collected, while Dukebox gives us access for accession, because we don't actually have access to the RedCap database. We only have access to when it was transferred to Dukebox, so that it's much easier to share within those who only have access to it. The RedCap database only has access to those who are initially collecting the data, so that we minimize manipulation or any changes. Instead of using the original data set, we use the one that is in Dropbox, which has been securely shared to the participants actually involved in the analysis itself. I hope that
do you know if it is a sync? So you talked about different samples, patients from the clinic, the validation sample. Are these separate data sets as well?
Yes, the 460 participants for the psychometrics are separate.
Okay, so that's another thing to be very specific on. You mentioned that in the language that's used on the participants and inclusion criteria and setting looks more like the language that you would see on the paper on describing your methods. But then here you need to be very specific that this sample of patients comes from a data set that is in Jukebox. This other sample comes from a data set that is in RedCap, because you're going to need to differentiate whenever people ask you, for instance, about where is the variable age. You're going to have to know where this variable is in one of these data sets. And also you would need to know how to combine them if that's necessary for the analysis.
Okay, so I should also include that. Okay.
Yeah, so in data management, I'll add a comment for that. So explicitly describe the data sets.
Okay. And should I include that in the data management or in the analysis of the population study? Where do I include this? Because this is the original, I think the template for SAPs, so it had this structure. So should I add more description to here with regards to analysis of populations and declare that they're two separate data sets, or specify that in the data management?
I would go for data management.
Data management, perfect.
I just wanted to follow up on what the question that was asked, just to clarify about RedCap. So as I put in the chat, RedCap is really not intended to be your long-term data storage site. And this is a general tip for everybody. It was great of Derrick to point out that, direct RedCap access could potentially allow somebody to kind of mess with your data, although there are ways to control for that. But it's better to put our data elsewhere, extract it from REDCap. Not to mention, it's always recommended to have even more than one backup, for which we often use Jukebox or other locations to store our data. So it's helpful to think of REDCap as our data collection tool, not really like the repository of our data.
Yeah, and following on that recommendation, actually, Derrick, do you know if this study has been concluded thus far? Is data collection done?
Yes, data collection has
Okay.
been completed. So we already have the full data set. We've mostly started exploring the psychometric, the 465 data set, but not so much with regards to the clinical cases. But I know there's two separate data sets or complete.
Okay. And do you have the dates where they were collected? Is that specified anywhere?
Yeah, I think there I must
Oh,
have.
it is. I see
Yeah,
it. 29th August 2024 and 30 November 2024.
Yeah.
Okay. On the variables, maybe on the variables or data management sections, it would be good to talk about what are the patient identifiers that you're going to use, especially if you're going to need to merge these data sets at a given point.
Okay.
Either by merging, what I mean is either you have part of this, you have data for the same patient split between the two data sets, and you have to merge them based on this identifier. Or if they are totally different samples, you still need to concatenate or join the data in like in a vertical way. So knowing specifically if the variables are the same, if you're going to need to, maybe age was collected in months in a data set and in years in the different data set. So at least knowing a little bit about that would be good. But yeah. Mm-hmm.
Okay, I'll try to include that with, so I'll have I'm wondering, should I have separate descriptions for variables in each data set and show how they're linked, or?
I would think so, but briefly. So imagine one thing that I feel like is quite useful is when you have multiple data sets is have a summary table where you have a table that has data set name, number of variables, main types of variables, population. Like those 4 columns should be more than enough for you to characterize the differences in the data sets in order for people to understand which of them should be used for different analysis, and how to handle them in case it's necessary.
Okay, makes sense.
How about you? Maybe Derrick, do you have any other questions that you want to get answers from? I know that I gave a few suggestions here and there, but was there anything specific that you think that the template wasn't ready, that needed some improvement, or anything on this specific project that you still need clarification?
Luckily, I don't have any specific questions because I had the help of Nathan to actually review this SAP. So most of the questions and comments were actually addressed by him. So
Nice.
most of this presentation was just to get additional feedback before we actually proceed with the analysis or exploration for the second data set so that we can actually begin the psychometric analysis.
Perfect. That's good to hear.